I'm Dr. Minh Huynh, Medical Oncologist and Medical Director at NantHealth. I'd like to share with you my top cost savings opportunities centered around the most costly drugs. Over the years, we have seen phenomenal advancements on oncology, and we see this in the results of our patients. But with advancement come challenges. How do you know when the new regimen should be used, or when the established regimen is the better choice? This is where treatment plan validation comes in. Let me give you an example. Immune checkpoint inhibitors are a relatively new class of drug. They target checkpoint proteins, preventing them from binding their partner proteins, allowing the patient's T cells to attack cancer cells. The first one was approved in 2011 for melanoma. Since then, there's been 8 more approved, and they cover virtually every solid organ tumor type. In a specific case, we had a 64-year-old woman with a metastatic stage 4 non-small cell lung cancer. She was treated with chemotherapy as well as immune checkpoint inhibitors. She had a wonderful response and was placed on maintenance pembrolizumab. At the 2-year mark, her treating oncologist wanted to continue her on the pembrolizumab since she was tolerating the drug so well. This, however, is not consistent with evidence-based medicine. He called in and we had a clinical discussion. We reviewed the FDA label, the KEYNOTE-021 trial, and NCCN guidelines. After consideration, he agreed that he would save the pembrolizumab for when or if the cancer came back. This approach not only spared the patient potential toxicities without clear clinical benefit, but also saved the health plan $150,000 a year. Let's talk about growth factors. ESAs, or erythropoiesis-stimulating agents, are often used to treat anemia. When you don't identify the underlying cause, these treatments may be ineffective and expose patients to unneeded toxicities. Another example are myeloid growth factors. These are used to decrease the incidence of neutropenic complications. These, however, do not need to be used with every single regimen given. In a recent case, I had a peer-to-peer discussion with a provider who requested myeloid growth factor for a woman being treated for metastatic colon cancer. The patient was being treated with FOLFOX and bevacizumab. After a discussion with the MD, he actually agreed with us that this regimen had a very low risk of neutropenic complications and that she had no other extenuating circumstances that would necessitate use of myeloid growth factors. He decided to reserve the myeloid growth factor for use in the future if needed. He saved the patient from potential toxicity, as well as the health plan saving, on average, $3,000 to $6,000 a month. As you can see, treatment plan validation helps members receive evidence-based medicine while ensuring cost reduction. In fact, we saved a health plan over $38 million in a year by simply ensuring that their members received appropriate evidence-based care.